Yes, Doc, you can start now.
Okay, so we are live now.
Yes, it's fine now.
Okay. Bismillah ar-Rahman ar-Rahim. Allahumma salli ala Muhammadin wa ala alihi wa sahbihi wa sallim. And Assalamu alaikum all of you. My name is Muhammad Ibrahim. I'm lecturer at Amud University and University of Hargeisa. And in this presentation, I will talk about the sonographic characterization of thyroid nodule. We will ask about what is thyroid nodule, what is the role of ultrasound regarding thyroid nodule, what answers can we get for our question about thyroid nodules, how can we describe a nodule, and how can we find the nodule at risk to be malignant. And finally, we will discuss the TIRADS. So the first question is, what is nodule? Nodule is an area in the thyroid gland that's sonographically different from normal parenchyma. This is normal thyroid gland. It is homogeneous with medium level of echogenicity. And this is an example of area with different sonographic appearance. When compared with the other thyroid parenchyma, this we say it nodule. Ultrasound is an extremely sensitive tool in the detection of thyroid nodule. The role of ultrasound in thyroid nodule can be received in three main issues. Number one is to detect thyroid and cervical masses. And number two is to differentiate between possible benign and probably malignant. Possible benign and probably malignant masses based on their sonographic appearance. Number three, to guide the performance of FNA biopsy and percutaneous treatment. Thyroid ultrasound can provide answers to several clinical questions. Is the palpable mass within or adjacent to the thyroid gland? Is the tumor confined to the thyroid or locally invades nearby structures? Are cervical lymph nodes involved? Is there a primary focus in the thyroid gland in a patient with cervical lymphadenopathy? And finally, is there a post-operative residual or recurrent tumor in the thyroid bed or metastasis to the neck lymph nodes? Prevalence of nodule. The prevalence of palpable thyroid nodule in adults is 7 to 21%. On ultrasound, it has been demonstrated in 40% of asymptomatic patients, and by autopsy, the thyroid nodule is around 50%. Therefore, physical examination alone is not a sensitive method for detection of thyroid nodules. Benign lesions, more than 80% of nodular disease are found to be benign and not need for biopsy. Benign thyroid adenoma comprises 10% of focal nodular disease, and only 5 to 10% are found to be malignant. So the role of ultrasound is to evaluate nodules and indicate whether a biopsy is necessary. And the challenge is to reassure the majority of patients who have benign nodular disease and diagnose the minority malignant. Cyst in the thyroid gland is thought to be cystic degeneration of follicular adenoma. Its appearance on ultrasound corresponds to their degenerative changes. As we all see, it must be anechoic, smooth wall with posterior enhancement and well-defined. Follicular adenoma. Follicular adenoma is benign tumor of thyroid follicles. It is usually single, well-encapsulated lesion. The other area of the gland usually appears normal. And sonographically, the follicular adenoma appearance has a spectrum of appearance that depends on the contents. It can be hypoechoic, isoechoic, or hyperechoic to the normal thyroid tissue. Most adenomas are solitary, solid homogeneous lesions with regular margins and oval or round shape. They tend to undergo cystic degeneration. An echoic peripheral halo might be seen with adenomas. However, halo might be also present with malignant lesions and is therefore non-specific. Adenomas might also have localized peripheral calcifications or might be entirely calcified that resembling like a calculus. So this is an example of adenoma, solid, well-defined mass with a hypoechoic halo. This is an example of adenoma and again cystic degeneration. It has here a halo surrounding the area of the follicular adenoma. Malignant lesions, carcinoma of the thyroid are in multiple nodules. Carcinoma of the thyroid are very rare. Small percentages of single nodular might be malignant, but when it is multiple, the nodule, the risk will decrease more. Nodules at risk will decrease more. Most thyroid cancers are relatively non-aggressive and have good prognosis with 90% have 10 years of survival. Carcinoma is the most common type of the thyroid carcinoma. It comes 70 to 80%. The next most common is follicular carcinoma. The other types of medullary, anaplastic, and lymphoma are very, very rare. Papillary carcinoma is the most common type of the thyroid carcinoma. It is 2 to 3 times more common in women, also more common in young patients between 25 to 35 years. Radiation exposure is the most common factor. Sonographically, papillary carcinoma is hypoechoic in 90% of cases. Microcalcifications are seen with or without posterior shadowing. Hypervascularity is not observed. Approximately 20% of cases show lymph node metastasis. This is an example of papillary carcinoma. Hypoechoic nodule, speculated, ill-defined margins and speculated with multiple or many calcifications that are very small calcifications. Some of them has posterior shadowing. This is another example of typical papillary carcinoma. It is solid, hypoechoic tumor without capsule. Here we can see ill-defined margin even infiltrated into the negus or adjacent structures. There are multiple small calcifications in the solid area without shadowing. This is due to this is a cystic papillary carcinoma. It's not completely cystic. It is dominantly cystic. There are here areas of solid with multiple calcifications, punctated small calcifications. And here we can see color Doppler showing hypervascularity. Follicular carcinoma is the second most common type of thyroid cancers, well differentiated and developed from follicular cells. Solitary, mostly some of them are well defined, well encapsulated, and less invasive, whereas others are not encapsulated. It means widely invasive tumor. Sonographically, might show irregular margins with thick irregular halo and tortuous internal blood vessels. This is an example of follicular carcinoma. It is solid. Here it is solid, hyperechoic, with irregular thick halo. The halo is here is very thick, irregular and areas it's marginal and real.
Sir, your slides are not going forward properly. I think it's internet connectivity issue.
My is showing me the internet is not stable.
Try to stop your video, then try again. I think that would work.
Now you can see the slide.
Yeah, the slides are visible, but they are not synchronized with what you are saying. And like if you are on slide number 2, and but it's showing your slide number 1 still, like it's not proper.
Okay. Now which slide can you see?
This is a medullary carcinoma.
Okay. I'm there. So should we continue?
Yeah, if anything happen, I'll let you know.
Yeah, I think now
You can start. You can start.
Okay, sorry for inconvenience. The internet was not stable. Medullary carcinoma. Medullary carcinoma accounts for 5% of thyroid cancers. It is often familial and essential components of multiple endocrine neoplasia type 2 syndrome. High incidence of metastasis involvement of lymph node has been reported. This is an example of medullary carcinoma. Appears like papillary carcinoma. It is solid, hypoechoic, with multiple calcifications that appears very echogenic and very bright, with multiple calcifications. These are areas of invading the adjacent structures, and some areas it is well defined, but this is called jagged margins. And this is the lymph node of a patient, appears round and hypoechoic, and this suggests metastatic sign of related to the medullary carcinoma. Now we are going to discuss the characterization of thyroid nodules, and these characteristics are well-documented signs that can be used in differentiation between benign from malignant. Identifying these relevant signs of benignity and malignancy in thyroid nodules can be used to provide a helpful ultrasound diagnosis and decide which nodule should undergo biopsy. We will see the size, texture, margins of the nodule, presence or absence of halo, calcifications, vascularity, lymph nodes. Let us start with the size of the thyroid nodule. In short, the size of the thyroid nodule is not helpful in distinguishing a malignant nodule from benign nodule. The nodule size should be precisely documented for the purpose of follow-up. Although in principle, the size of thyroid nodule should be measured in all 3 dimensions, but only the maximal diameter of the nodule can be measured and documented. When measuring the nodule size, it is advisable to locate the caliper's outer margin of the halo of the nodule. According to the American Thyroid Association guidelines, a reasonable definition of growth is a 20% increase in the nodule diameter. Although malignancy is believed to grow more prominently than benign, but even benign nodules can grow with the time, and about 90% of benign nodules have demonstrated increase in volume by 15% over a 5-year follow-up period of time. Cystic nodule showed slower growth than we usually see in solid nodules. In this study, we can see 150 nodules reported as malignant. On fine needle aspiration. 83 of them were less than 1 centimeters. 83 of them were less than 1 centimeters. Where 67 of them were more than 1 centimeters. On the other side, 823 were diagnosed as a benign. Almost 45% of them were less than 1 centimeter. The other 55% were more than 1 centimeter. The mean diameter of the benign nodule was 1.2 centimeters, and malignant nodule is 1 centimeter. So the size of the nodule here, we can see the size of the nodule is not significant in differentiation between benign and malignant nodule. The next characteristic is in the texture and echogenicity of the thyroid nodule. It can be hypoechoic, isoechoic, or hyperechoic. It can be also solid, cystic, or mixed. Most of the cancers are hypoechoic, but the dilemma is that also most of the hypoechoic lesions are benign, because most of the common thyroid nodules are benign. So there must be another feature. Hyperechogenicity is a strong feature of benign nodule, especially if associated with a cystic area. Also, if nodule is uniformly hyperechoic with thick halo, it favors malignancy. This is an example of solid hyperechoic nodule with cystic area, suggestive of benign nodular hyperplasia. This is another example of solid nodule, but this nodule is homogeneous and uniform in addition to the thick halo that suggests malignancy. This typical hypoechoic solid nodule with irregular margins in some areas, showing high probability of malignancy. And this predominantly cystic nodule with areas of solid parts and containing calcifications in it. With color Doppler, this solid area showing blood flow. As we mentioned before, nodular hyperplasia may undergo cystic degeneration, and usually it contains solid parts. But what makes a difference in this nodule, in these two nodules, is the calcifications and blood flow in the solid parts. If we see a calcification in a solid parts or an area of blood flow, then we consider this most likely a malignant nodule. And this is cystic area with a cystic nodule with echogenic foci in it. And here we can see comet tail artifact behind the foci, and this is typical colloid nodule. This a sponge-like nodule. It is multiple cysts of thin septations. This indicates, if we see like this, it indicates it is a benign nodule. The other sign that should be observed is the calcifications. Calcifications are found in around 1/3 of the thyroid nodule. It is common in both benign and malignant disease, but the risk of malignancy will be high if it is solitary, if we find it in a solitary nodule, and if it is punctate or small microcalcifications. Microcalcifications are less than 2 millimeters. It is two type 1 with common tail artifact like this. It is usually found in a cystic nodule or complex nodule. It is thought to be thyroid globulin concentration. When calcification with common tail artifact is seen, it is strongly indicates to be benign. The other punctate type of calcification is worrisome, like this. It has no common tail artifact. It is here without distal acoustic shadowing, and because of its small size. So whenever we see a punctate calcification with no common tail artifact, we should biopsy it. Coarse calcifications are the other type, which is more than 2 millimeters in size, usually common in multinodular goiter. It is worrisome if it is found with solitary nodule or nodule of mixed nature associated with other microcalcifications. This is a solitary nodule with coarse calcifications that are more than 2 millimeters offshore, and many other small calcifications. This is going to malignant side. This is another example of coarse calcifications in infiltrating hypoechoic solid nodule. There are also other microcalcifications, such as of papillary carcinoma. There are the big one is here. There are many other small calcifications, punctate calcifications with a shadow that's giving a sign of malignancy. This is a study published in January 2011, and over 4,000 patients were examined. There were 1,391 malignant cases. Calcifications were seen in almost 1,725 patients, which is around 41%. The significant number here is the incidence of malignancy was over 96% for patients with microcalcifications, and 41% for patients with macro, or the large one, the macrocalcifications. Sometimes we see peripheral calcifications. Peripheral calcifications is defined as a bright echoes observed on the surface of the thyroid nodule without acoustic shadowing. Peripheral calcification is one of the patterns of the dystrophic calcifications located around the nodule. It was generally thought to be more frequently associated with benignity. However, there were cases of papillary carcinoma associated with this type of calcifications. So there was a study. In this study, 14 cases of surgically proven thyroid nodules with eggshell calcifications were reported. 6 of them, which is around 43%, were malignant, and all of these 6 were papillary carcinoma. 8 cases were benign, including 5 cases of follicular adenoma and 3 cases of multinodular goiter. Another study of 93 surgically proven thyroid nodule with eggshell calcifications showed almost 63% were malignant and 36% were benign. All of the malignant nodules were papillary carcinoma. And benign nodules include 33 adenomatous hyperplasia, and 1 follicular adenoma. This is a well-circumscribed isoechoic nodule with a ring, smooth curvilinear calcifications. Here, all of it. There is calcifications around it. This is called eggshell calcifications. This is surgically proven. It is confirmed to be adenomatous goiter. Another example, this is spherical hypoechoic solid mass with area of interrupted, here, eggshell calcifications. This is with the biopsy, it's diagnosed as a follicular thyroid carcinoma. This nodule is a hypoechoic mass surrounded by thin hypoechoic halo around it. The internal architecture of the nodule is not visible because of marked posterior shadowing here. On fine needle aspiration, it's diagnosed papillary carcinoma. And this is an example of peripheral calcifications. Here it is an oval shape. It is proven to be papillary carcinoma. So the spectrum of these 4 examples, we can see if the nodule has axial calcifications, it can be benign or it can be malignant, but we have to biopsy it. Then the other character is the margin of the nodule. It can be categorized as a smooth or speculated, microlobulated, or ill-defined. Early studies have reported that speculated, microlobulated, and ill-defined margins are suggestive of malignancy. Speculated means jagged edge with sharp demarcation. Well, we call it poorly defined or ill-defined margins when the nodule cannot be differentiated from the normal parenchyma. But also benign thyroid nodule, also known to be incompletely encapsulated and poorly marginated, and they can be merged with the normal tissue. Therefore, an ill-defined margin is a non-specific finding that is seen for both benign and malignant nodules. In contrast, if we see a speculated margin, it is highly suggestive finding of malignancy, with suspicious of almost 92% and positive predictive value of almost 81%. This is an example of well-defined encapsulated nodule with thin halo around it. This is suggestive of benign follicular adenoma. And this is a nodule of microlobulated, infiltrating the adjacent structures, and this is suspected of malignant nodule. And this is solid nodule, well-defined in some areas, like here, it is well-defined and ill-defined in some areas, and this is probably going to the malignant side. The halo caused either by the capsule. To see a halo, it is only either by a capsule of the nodule or due to the adjacent compressed thyroid tissue. It might be thin or thick halo. Thin and regular halo is seen in 60 to 86% of benign nodules and is usually seen surrounding hyperechoic or isoechoic nodules. It represents compressed vessel. But thick irregular halo is a sign of neoplasm. It's believed that nodule is compressing adjacent tissue, and because of lazy nature of the thyroid cancer, this tissue manifests itself as a halo surrounding the carcinoma. Absence of halo is more suggestive of malignancy. This is an example of thin halo surrounding an adenoma with cystic degeneration. And this is halo surrounding solid homogeneous mass indicating follicular carcinoma. So both of them, it's showing halo, but the halo alone is not indicating malignancy or benignancy. In this halo, there is solid part and cystic area. It is showing degeneration, but in this nodule, it is predominantly solid and homogeneously solid with a thick halo, so it is going more to the malignant area. The vascularity, there are 3 patterns of vascularity in the thyroid nodule. It can be either divided into 3 types. Type 1, absence of follow signal, completely absence of follow signal within the nodule. Type 2, exclusive prenodular follow signal. And type 3, intranodular follow with or without prenodular vessels. Type 3 pattern is generally associated with malignancy. Type 1 and type 2 are more commonly seen in benign hypoplastic nodule. But as the other characteristics of vascularization, it is used as the only, if it's used as the only predictor of malignancy, it will not give you a very good indication of either malignancy or benign. It will not be accurate. It should be used in combination with other features. This is type 2 color follow pattern with solid hyperechoic nodule. And this is type 3 follow pattern, internodular follow in hypoechoic with irregular irregular margins, and there are small areas of calcifications. The last characteristic is the lymph node. Normal cervical lymph nodes are rarely visualized by ultrasonography. However, hyperplastic lymph nodes appear in many diseases as they are seen with high accuracy. Benign as well as malignant lymph node has typical sonographic morphology. Benign lymph node appears as an oval and hypoechoic with smooth borders and hyperechoic hilum, which represent hilar fat and small vessels. Malignant nodules have different manifestations. It can be more round, as it is here, of a heterogeneous structure, commonly hypoechoic with a loss of hilum, sometimes with a cystic degeneration, or sometimes calcifications, as it is here. On color Doppler, it can show increased blood flow like it is here and here. But however, the fine needle aspiration still remains the most accurate tool for confirming or excluding malignancy. This is a review of the literature of the radiological science that can predict thyroid carcinoma. Many researchers propose to use these criteria to identify which nodule is more likely to be malignant and should undergo fine needle aspiration. Of all features, we have seen the solid hypoechoic lesion with microcalcifications is the strongest indicator of malignancy. Also, we can recognize here that the predictive ability of ultrasound for malignancy is effective only when multiple signs are present in the same nodule. Also, we can note in this review that summation that we can note that their predictive value increase in summation means when we use multiple characteristics in one nodule, but their sensitivity also will decrease. Then let us see the TIRADS. The spectrum of signs that are available in differentiation of benign and malignant thyroid nodules can be incorporated into a radiological classification system that is similar to that used in the breast, which is called, in the case of the breast, it's called BIRADS. But in the case of the thyroid, it is known as a TIRADS, Thyroid Imaging, Reporting, and Data System. It is a reporting system for thyroid nodule on ultrasound proposed by the American College of Radiology. This uses a standardized scoring system for reports, providing users with recommendations for when to use or when to recommend FNA and when to not recommend FNA. Thyroid describes normal thyroid. And so we say thyroid 1 describes normal thyroid where there is no nodule. Thyroid 2 probably benign if we see probably benign thyroid nodule. And that lesion is cystic nodule with calcification is having renowned artifacts. It is colloid cyst. like this. In this thyroid one, it is normal thyroid gland where there is no any nodule. Thyroid 2, it is probably benign because it is cystic degeneration, cystic lesion with the calcification that has colloid that has a ring down artifact. Probably it is colloid ring down sign. And this is another thyroid 2 scored. This is probably benign because it is cystic with peripheral blood flow. Thyroid 3 describes in the case of indeterminate lesion. For example, this is solid, homogeneous, and echogenic with well-defined halo. This follicular lesion, and 80% of like this follicular lesion are benign, but the 20% of malignancy may also have the same features, so we have to biopsy. So this, we score it as a thyroid 3. And this is thyroid 4, describes suspicious lesion, means it has features of malignancy, but it's not strong enough to say malignant. Like this lesion, it is hypoechoic and homogeneous, but the color Doppler show peripheral flow. Thyroid number 5, or level 5, indicates malignant lesion with or with more than one feature. Here we can see it is ill-defined, hypoechoic with multiple small calcifications. And this is invading the adjacent structures, and this is more likely to be malignant. It has more than one features of malignancy, so it is thyroid 5. Again, this is thyroid 5. It is metastatic lymph node. There are areas of cystic and solid, and there are multiple small calcifications. So in conclusion, in the clinical workup of a patient with suspicion of thyroid pathology, ultrasound should be the first imaging test. When ultrasound demonstrates a nodule suspicious for malignancy, then FNA should be the second diagnostic exam under the ultrasound guidance. Thank you. Then if there is any question.
Yes, there is a question. What was the size of enlarged lymph node?
Normally, the lymph node is not seen. If it is normal, it's not usually seen on ultrasound. Whenever you see a lymph node, that means it is more than the normal size. So the other thing is not the size only. When we describing the lymph node, we describe the echogenicity and the shape of the lymph node. Normally we see it is smooth, and the content is echogenic hilum, and the hilum here is due to the fat and blood vessels. But when you see it is large and it is losing these normal features, that means you are dealing now going this lymph node should be biopsied.